Hi, my name is Sanjay Patel. I'm an assistant professor at the University of Oklahoma, and I'm going to be talking to you about the take-home points from the AUA 2019 meeting. The AUA program had 61 sessions related to prostate cancer. That's certainly a lot of sessions. It's like, as with the rest of the AUA, is like drinking water from a fire hose. But I try to summarize some of the more salient aspects of the meeting here and try to review them in the next 10 minutes. And I want to talk to you about opioids, the Tulsa trial, BRCA germline testing, the CALGB trial, and gallium PSMA PET scans. And so I'd like to first start by talking about opioids. Ben Davies at the SUO session discussed in length about opioid use. About 75% of opioids come stolen from friends, family, and relatives, and approximately 75% of opioids that are prescribed are ultimately not used by the patients and are stored and then become abused by other people. If you look at this as a plot of mortality over time secondary to opioids, you can see here in the 1980s, between then and 2016, there's an exponential increase in the amount of opioids that have resulted in mortality. Dr. Davies outlined his protocol for the non-opioid radical prostatectomy pathway that they have at his institution, which involves a combination of factors, including preoperative factors such as neurontin and acetaminophen, quadratus lumborum block, intraoperative measures, including separate infusions of propofol, ketamine, and Precedex, and also a postoperative pathway, namely using Toradol and Tylenol, as well as Motrin. Using this pathway, he found that the average number of opioid pills prescribed decreased from 40 prior to the implementation of the program to about 20, to 2 after the implementation of the program. And so certainly a significant reduction in the amount of opioids consumed, really underlining or underscoring the fact that we overprescribe opioids and that many opioids are not needed, and it can be really pared down to probably single-digit prescriptions. Dr. Davies also mentioned that more people died of opioid overdose than prostate cancer last year, certainly putting it into perspective for us all. Persistent opioid use should be the #1 surgical complication, and over 95% of men really don't require opioids after prostatectomy, and they should not routinely be ordered. Certainly, this was the theme of many other abstracts. Christian Steinsland, in an analysis of 117 patients undergoing prostatectomy, assessed the amount of narcotics given to patients by assessing them through a sheet that they gave for the patients to record. And basically, they found out that about 52% of patients took 0 pills at home, and about 91% took fewer than 10 pills. Certainly, they went back in the data and looked at predictors of use, and they found a correlation between the amount of narcotic use in the hospital and postoperative pain score in the hospital. So certainly, these are things that we can use to tailor how many antibiotics are given to each patient on an individual basis to reduce the opioid load. Dr. Parth Shah presented data from the music collaboration in Michigan, presenting the statewide experience of a new program, which was a collaboration with music and Blue Cross Blue Shield. Basically, they developed a pain optimization pathway for patients undergoing prostatectomy. They incentivized urologists to do this pathway by giving them a 22 complex surgery modifier for the prostatectomy if they participated. It involved preoperative, intraoperative, and discharge means to reduce the amount of opioids. And particularly at discharge, all patients were given 6 tabs of oxycodone, and they were also given a phone call afterwards to monitor this. In general, after this program, the average consumption of opioids was about 3 tabs of 5 milligrams of oxycodone consumed by patients. This really provides a good benchmark to guide postoperative opioid use, and really supports translation to other surgeries where we could utilize such pathways. So at the end of the day, I think we as a whole, as urologists, particularly those who treat prostate cancer with prostatectomy, should really revisit our perioperative, postoperative pain management pathways, in particular focusing on reducing the amount of opioids prescribed to patients, really reducing the amount that are out there in the general population. So certainly we should all challenge ourselves to improve on this for this year. Next, I want to talk about the MRI-guided ultrasound ablation trial, which is a Tulsa trial. It was presented by Scott Egner. Basically, they utilized a transurethral device that emits ultrasound energy to ablate a certain volume of prostate using an MRI guidance device. There's a whole protocol here that's outlined. And basically 13 centers across the U.S. Participated. Inclusion criteria included patients with less than T2, clinical T2B cancer, PSAs less than 15, and Gleason scores less than or equal to 7. It was the Tulsa technology was used for whole gland ablation in the 115 patients that they had, which had an average gland size of about 40 cc's. Over 96% reached their primary endpoint, which is having a greater than 75% reduction in their PSA. Again, this is at 1 year, and overall they determined that there's a low side effect profile. Low 8% had grade 3 toxicity, 96% had return to continence, and about 75% were still potent. So certainly demonstrates promising results with this Tulsa technology with overall low rates of toxicity. Certainly more data and longer follow-up are needed, but certainly this adds to the armamentarium of existing localized treatment options for patients with prostate cancer. Next, I want to talk about BRCA testing, which is germline testing in men with prostate cancer. Dr. Todd Morgan presented at the SUO session, basically stating that about 1 in 10 men with metastatic prostate cancer has a germline DNA mutation. And germline DNA testing is utilized in other cancer sites, namely breast and ovarian, and certainly those are incorporated in the breast guidelines. And so in prostate cancer, germline mutations in BRCA1, 2, and ATM are associated with increased upgrading in men with active surveillance, and also are associated with worse metastasis-free survival and cancer-specific survival, having those factors. So certainly they have a prognostic impact. Certainly with just like with anything, when you're talking about DNA testing and germline testing, there are certain ethical considerations. Dr. Morgan described the Genetic Information and Non-Discrimination Act, and basically stated that this prohibits health insurance companies and employment discrimination based off of this testing. However, despite that, there are still certain aspects where you are not immune from discrimination, and certainly those are in life, disability, and long-term care insurance. So you certainly have to consider that and have a discussion with patients before considering this germline testing, as it has other impacts other than cancer and care. Lastly, he concluded stating that we're entering a brave new world. Ultimately, with prostate cancer, inherited susceptibility to prostate cancer is complex and it's poorly understood. I think that he also mentioned that we all can and we should become experts in this area, because this is certainly something that may be incorporated in our practice. And we also, as urologists, need to understand the pros and cons of testing and all the unique aspects of it. Just like any test we order, germline testing has its pros and its cons. Next, I want to talk about the CALGB trial. This is presented by James Eastham, the PI of this trial. It's basically it's a very commendable trial occurring over 17 years, and the data had just matured. And so basically in this trial, they identified patients with locally advanced prostate cancer, and they randomized them to one of 2 treatment arms. One arm was 6 cycles of neoadjuvant docetaxel plus hormonal therapy, LHRH agonist therapy, followed by prostatectomy, versus prostatectomy alone. Their primary endpoint was 3-year biochemical free recurrence, which was defined as having a PSA less than 0.2. At the end of the day, with the primary endpoint at 3 years, there was no difference in the biochemical progression-free survival. There was, however, an improvement if you look at the entire cohort, not just the first 3 years, which was what the primary endpoint was, but if you look at the entire cohort, there was an improvement in biochemical progression-free survival in the neoadjuvant chemotherapy arm. However, approximately 42% of patients underwent additional treatments prior to reaching that endpoint, that PSA of 0.2, and it can certainly make the interpretation of the results from this trial challenging. In terms of overall survival, the trial did favor the group that got neoadjuvant chemotherapy and hormonal therapy. However, the confidence interval did barely cross 1 with a p-value of 0.06. In terms of freedom from treatment failure, it was improved in the neoadjuvant chemotherapy arm with at 10 years, 38% were free from treatment if they got neoadjuvant therapy versus 25% who did not. So certainly that is an improvement and certainly has an impact on the patient's overall quality of life. Future considerations with this trial are ultimately to look at the impact of neoadjuvant therapy on surgical outcomes, which include the margin status, nodal status, and that data is still pending. And perhaps some of the more important things is looking at the molecular tissue analysis. That analysis is pending, and really we could potentially identify factors, molecular factors that influence chemohormonal resistance and identify who will respond and who will not respond. So certainly interesting data that may be born from this trial. And lastly, I wanted to talk about molecular imaging. There are several posters and abstracts regarding molecular imaging, and particularly it's a problem that we all see as urologists is the staging problem after biochemical recurrence for patients who have prostatectomy or radiation therapy. Standard imaging studies with CT scans and bone scans have low sensitivity and specificity, particularly at low PSA levels. So it's really important for us to identify improved imaging modalities that will help us identify where the patient's residual cancer is after they fail primary therapy. And so Dr. Pete Carroll at the SUO session really discussed some high quality data using molecular imaging with gallium PSMA PET scanning and in a cohort of patients from UCLA and UCSF. All in all, he had about 635 patients with biochemical recurrence after they had primary treatment of their prostate cancer with radiation therapy or prostatectomy. He ultimately noted a very high positive predictive value for gallium PSMA, and particularly looking at the sites of recurrence. If you looked at all cases, these are all patients who had biochemical recurrence after prostatectomy or radiation therapy, and noted that even at low PSA levels, there was a high percentage of patients that had extrapelvic disease outside the pelvis, certainly would influence adjuvant treatment selection. And when looking at just the radiation naive patients, patients who had prostatectomies, he noted that the prostate bed is an uncommon site of recurrence. As you can see here, the red bar represents extrapelvic disease, and you can see here that comprises a majority of the cases of recurrence there. Ultimately, he concluded stating that gallium PSMA PET may help identify disease that may be outside the standard templates for lymph node dissection or for regional radiation. And it'll be really interesting to see how gallium PSMA will be incorporated into practice going forward, particularly in these patients that have biochemical recurrence after primary treatment. Thank you very much for listening to the summary of the AUA take-home messages from 2019.